we are around
This meeting is being recorded.
we are around a theme where we are saying immunization for all is humanly possible. We can be able to achieve so much together with immunization when we put all our efforts together as healthcare workers, public health officers, research organizations, clinicians, communities. We can all work together to make sure that our children are protected from vaccine-preventable diseases. We have a very special panel here with us today. And before they go into their presentations, I would like to invite them to introduce themselves. I'll start by introducing myself officially. My name is Ruth Wajala. I work at Path Kenya. I coordinate the vaccines and immunization portfolio at Path, and we work closely with the National Vaccines Immunization Program, as well as the other partners who are on this call, to make sure that our children are protected. So on that note, I would like to invite Dr. Mugambi to introduce himself. Dr. Mugambi, over to you. Dr. Mugambi, can you hear us? Okay, maybe as he gets ready, Dr. Tabu, please introduce yourself.
Thank you, Ruth. Colleagues, ladies and gentlemen, my name is Dr. Colin Stabu. I'm the immunization team lead at the UNICEF Kenya Country Office. Glad to be here amongst you all. Thank you.
Thank you so much. Dr. Mugambi, are you able to hear us? Okay, so it looks like you might be having some technical difficulties with his sound. Or you're able, okay, go ahead, Dr. Mugambi. Okay. Dr. Zimba, welcome to the webinar. We were just doing a round of introductions. Please introduce yourselves so that we can go to the presentations.
Thank you very much. Just to confirm if you can hear me.
We can hear you. Thank you.
All right. So, good afternoon. I'm Jumbo. So, my name is Dr. Boston Zimba. I'm the team lead for immunization program at WHO Country Office, Kenya. Happy to be part of this discussion, and I really want to appreciate the organizers. I think these are the things that we really need as immunization stakeholders. Thank you, Ruth. Bye. Back to you.
All right. Thank you so much, Dr. Zimba. Let me just check one more time if Dr. Mugambi is able to speak. Dr. Mugambi, please try again and see if we can hear you. All right. In the interest of time, maybe we can reach out to him and see what the challenge is. But at this point, I would like to kindly request Dr. Tabu to start us off by giving us a few thoughts around World Immunization Week and how UNICEF has been working together with the Ministry of Health to be able to protect our children from vaccine-preventable diseases. So, Dr. Collins Tabu, welcome, and looking forward to getting any questions or any answers so that we'll be able to take that after his presentation. Over to you, Dr. Tabu.
Yeah, so thank you, Ruth, and for your moderation of this. I will try to keep it short. I do not have a PowerPoint presentation, but mine is just to be able to utilize this opportunity to share reflections around, immunization, to share reflections around the importance of vaccines, to share reflections around the UNICEF contribution related to protecting our children, our women, our adolescents from vaccine-preventable diseases, and in between that, share about where we are and perhaps what the next few years look like for us. And also just acknowledging that, yes, I do, it is before me, and that I do know that I'm preaching to the converted. Sometimes it is a challenge, but nonetheless, it behoves us to just remind ourselves sometimes the successes that we have are not really visible. So just for starters, colleagues, ladies and gentlemen, why vaccines? Like I did share, that we are converted, but we just need to know that once our immune systems are trained to resist a disease, we are considered to be immune to it. And so before vaccines, we gained immunity by letting ourselves suffer from diseases. And if we were lucky enough, then we would survive. So, but this would be the naturally acquired immunity by letting ourselves suffer disease. So with naturally acquired immunity, we would suffer the disease, risk the complications, risk even death, which could be, could be debilitating if it happens to communities. You saw what happened during the COVID-19 pandemic, and vaccines were really very instrumental in stopping the pandemic. Beyond that, you're really a danger to the rest of the communities. Now, looking at vaccines, there are things we don't stop to think about, really what our vaccines have done for us. If you look around ourselves, you don't talk about vaccine resistance. You don't talk about the viruses, the bugs being resistant to vaccines. So vaccines, diseases have been able to circumvent drugs, antibiotics, by creating resistance, but this has not happened, is yet to be reported for vaccination. And they're much more cheaper than drugs to treat diseases or than the rehabilitation efforts that will be needed. Just for the record, within the country, we give vaccines for about 14 vaccine preventable diseases. But just to note, this includes at least 2 cancers, if it just didn't resonate with us. We have vaccines that protect against cancer of the liver and cancer of the cervix within our immunization schedule. So this is big enough, and you know what the cancers are doing to us as a country as it is. So it's really helped us as a country to reduce, and really globally, to reduce the burden of infectious diseases. And because of vaccines, we now have more children living to see their first birthday than any other time in human history. Basically, vaccines have been able to cut down close to 60% of the deaths within this age category. But of course, why we're having these discussions, of course, understandably, as we reduce the morbidity, as we reduce the mortality, the visibility and the benefit of vaccines really gets lost on us, and the safety of vaccines gains a bit more public attention than the effectiveness itself. But we do know that the vaccines are much more safer than therapeutic medicines as they were. And most of the times, really, even as we do get them, it is the people who are well. And so the focus is much more on the safety rather than the benefits that we've been able to achieve. Within the country, and according to the KDHS 2022, at least 80% of the children 12 to 23 months of age were fully vaccinated with the basic antigens. We've achieved tremendous coverage as a country with about 97% receiving at least the first dose of pentavalent, first dose of OPV, BCG, and all. But nonetheless, not many children stay on to be able to complete their schedule. Now, this is a danger, that when the children do not complete their schedules, then they're vulnerable to diseases. So beyond this, again, with children not being able to complete their schedules, there is huge disparities in immunization coverage, really, of key antigens across different regions and socioeconomic groups. There is persistent stagnation really among these subnational levels, these geographical groups, mainly the nomadic pastoralist populations, the hard-to-reach areas, but even the urban poor. And most of these people are barely able to get even the first dose of any of the vaccines. So they're accumulating what would call huge numbers of zero-dose children who've never received a single vaccine in their lifetime. So just highlighting to you that really the story of the zero dose children who've never received any single dose is really overwhelmingly a story of inequities where communities are marginalized. They live in challenging settings such as remote rural communities, hard to reach areas, they're urban nomadic, they're nomadic pastoralists, so they live in urban slums really, or areas that are affected by conflicts and really move around a lot. And so these really, especially if they exist in clusters, they really pose a risk to harboring disease outbreaks within the country. And according to the KDHS 2022, approximately 48,000 of these children, of children under 1 0 dose children, they never get any vaccines. You can imagine that these accumulate over a 5-year period. They form communities who can harbor an outbreak. Reaching these children within our contexts is challenging, but of course possible through implementing tailored approaches, which the country has done at targeted community level outreaches. We have had supplementary immunization activities, and of course, enhancing community engagement. The country is currently implementing and providing for catch-up vaccination within its routine immunization service delivery schedule, but also when we do have supplementary immunization activities, really as an effective strategy to reach zero-dose children. Often, really, the vaccines are provided really to all and sundry, regardless of the previous vaccination status, just to boost population immunity. So as UNICEF, we've been really supporting and alongside the global health partners, including the Gavi and WHO, we've really been supporting the strengthening of the supply chain systems for vaccines, syringes, consumables, and other injection devices, vaccine delivery devices. We've been supporting to enhance the storage capacity for vaccines. As you do realize, vaccines are stored under very special and controlled conditions, but must be regulated between 2 to 8 degrees to really maintain their potency, ensure their quality, and not just that, vaccines are expensive. You can imagine every year, the worth of vaccines utilized within the country are worth more than 6 billion Kenya shillings. These are commodities you don't want to bring in and let them lose their potency, lose their quality just because you're not able to have proper storage, specialized storage facilities for these vaccines. Beyond this, we've been at the forefront for supporting to address vaccine hesitancy within communities, of course, aiming to reach the most vulnerable groups, including the ones that I spoke a bit earlier, the hard-to-reach populations, the urban slums, the nomadic and pastoralist populations that are special and unique in their own ways, working and supporting the Ministry of Health, the country, the National Immunization Program to tailor strategies to be able to reach these. Of course, this is in response to the main challenge for the immunization program, really, which is ensuring that immunization services are recognized and accepted by the public, especially of these vulnerable and marginalized groups, and that the vaccines offered are of the highest quality, that are affordable and accessible to all Kenyans at all levels. So in summary, if I never said anything, we're all working jointly with global partners here in support of the government to ensure that we have uninterrupted vaccine availability, accessibility, and affordability as a critical way in addressing, the coverage challenges. And belying all these is the engagement and involvement of communities in the planning, implementation, and monitoring of the immunization services to mitigate against all of these challenges. Without communities, ladies and gentlemen, we are not able to get anywhere. So the involvement and engagement of communities, their participation, communities taking a leadership position is critical, really, and it's at the forefront of all of our programming. So the World Immunization Week 2025 provides really an opportunity for all of us as a community to reflect on the progress made in preventing life-threatening diseases, of course, and reaffirm our collective commitment and responsibility to ensuring that everyone, regardless of where they are, regardless of where they live, regardless of who they are and their circumstances in life, have access to life-saving vaccines. It also provides for us within this period just an opportunity to get together and be forward-looking in terms of what the role of immunization will be in the coming decades. Of course, with a focus on reaching more people with vaccines, developing new vaccines to cover an even broader range of diseases and and ages. And, of course, as you will see, you may be told from our MOH counterparts, we're looking to introduce other vaccines, other schedules in just this year alone, and that would go away in supporting these. Ladies and gentlemen, just having shared these broadly and without going into the details, and as I said, because I'm speaking mostly to the converted, it is clear for all and sundry to see really that vaccines are undoubtedly one of humanity's greatest achievement. The vaccines we have contributed much more to public health than any other interventions, just coming second to safe and clean water. Ladies and gentlemen, as a community, let's rally together for collective and put together collective effort to protect our future generations from vaccine-preventable diseases. I'd just like to stop here, but perhaps in the Q&A, I'm happy to go into a lot more granularity in terms of what our contribution has been, in terms of what the strategies would be, and in terms of what the future then portends for us in the era of vaccines. Thank you.
Thank you. Thank you so much, Dr. Tabu. That was an eloquent summary. Thank you for shining a light on the zero-dose children and the inequities that surround them, as well as the contribution that UNICEF has had. So I know we have a session on the Q&A where we'll be able to respond, or the questions will be responded to. And if there are any questions, I would invite our attendees to be able to put those questions on the chat, and then we'll have a Q&A session where we'll be able to respond to them. So thank you so much, Dr. Tabu. And at this point, I would like to try again to see if we can reach Dr. Wesley Mugambi and if he's able to hear us. Dr. Mugambi, over to you.
Hello, Ruth.
Hello. Thank you. I think we can hear you clearly now.
Thank you.
We would like to invite you to introduce yourself and maybe just go straight to the presentation or the reflections from the National Vaccines and Immunizations Program, and also to share just your reflections on this World Immunization Week with our participants. Over to you.
Okay, thank you. I think at this moment I'll put up my presentation. As I do that, just a disclaimer, I do not look anywhere close to what might be appearing on your screens. I had to try and, do another gadget to fix the sound problem. So allow me to share the presentation, then we'll proceed.
Thank you. Please put any questions on the chat and we'll be able to respond to them.
Are you able to see my screen?
Yes, but I don't know if you can put them on slideshow. Maybe Nelson, you can help us to support Dr. Mugambi in case he's not able to share from his device.
Dr. Mugambi, we can see your screen.
I don't know why. I'm not sure why it is not, displaying the presenter here. I can see it from my screen. Let me just try and do it again one more time. Okay. This week from the 24th of April. And our theme for this week has been immunization for all is humanly possible. Traditionally, I know people have associated with immunization with children. We have been moving away from childhood vaccinations to what we are now calling life course vaccination. I'll be talking to you more about that. But perhaps also to highlight what Dr. Tabu said is that we have made very significant gains in immunization over the years. So for example, in the past 50 years, vaccines are estimated to have saved at least 154 million lives. That is now almost triple the population of the country at the moment. And to put that again into perspective, that is about 6 lives every minute. 6 lives a minute every day for 5 decades. So, of course, many people have associated, immunization with, things that are familiar with them. When you talk about vaccination in the community, people are going to tell you about COVID-19 vaccines, but we have quite a huge array of portfolio of vaccines that are available globally in the country. We have around 13 or 14 vaccines, but they cumulatively help prevent, immunize against a total of actually 20 vaccine preventable diseases. You look back to the history of immunization, we began way back in the 1400s, where people used to, have prevent their loved ones from getting smallpox. And basically what they would do is that they would just send them to places where they had exposure to smallpox, in limited, in a controlled environment. And what that would do is that it would, trigger the immune response, of course, to be immune to smallpox. But bringing the story back home, of course, we started our immunization program as it is in the 1980s. We started with around 3 antigens, that is BCG, measles, and the polio vaccines. Our portfolio, as I have alluded to, has grown to, prevent against almost 20 infectious diseases. Now, but more to that, still on that, we were able to eradicate smallpox in the 1980s. And as a country, we have made very, very huge gains. So very recently, of course, when you're talking about, for example, COVID-19 disease, the havoc that it caused globally. It is estimated that it was able to avert, close to 4 million deaths globally. And the story is more or less the same as hope as in our country. In 2019, we were able to introduce HPV vaccination that is able to prevent against cervical cancer. That is one of the 2 cancers that Dr. Tabu had alluded to. This vaccination is available all girls aged between 10 years and 14 years. So we are projecting that in the next decade or 2, when these girls now start becoming, turning to the ages, the reproductive age, around 30, 40 years, in the age of around 30 to 40 years, we are going to be seeing a lot of reduction in the number of cases of cervical cancer that are reported. But globally, what we are saying is that it is now projected that in between 2021 and 2030 globally, we are going to be preventing close to 51 million deaths simply because of vaccines. So this is now what we are calling, a huge public health intervention. I will try and demystify what the work that we usually do as the Ministry of Health, that is the National Vaccines and Immunization Program. Most of you know this as the API program, or the expanded program on immunization. That is, incepted first in the 1980s. But of course, we have changed quite a bit. At some point, we used to be called the Division of Vaccines and Immunization. Right now, we are called the National Vaccines and Immunization Program, basically just doing the same thing. So we have our footprint in all the 47 counties. We have a target population for our communities of around 1.7. That is our target age group for below 1 year. Then for the under fives, we are talking about 7.3 million. And for COVID-19 vaccines, during the height of the COVID pandemic, we had a target population of close to 30 million. So we usually do the vaccine supplies, importantly, through a system that is a bit different from what you know. We do not, for example, use KEMSA. We have our own central vaccine stores in Kajiado County or in Kitengela. So it is able to house all these vaccines. Then we have 9 regional vaccine stores, and then around 306 sub-county vaccine stores. This has been growing over the years. And then we have our nurses basically doing the bulk of the work, and we are present in almost 8,000 or 8,500 facilities out of the 15,000 health facilities. So we have a very strong, primary healthcare network. So we also usually, of course, collaborate with other divisions and departments within MOH, including the disease surveillance and among others. So basically, that is just trying to show where our vaccines are usually stored. That is the regional depots. Traditionally, they used to be what you would have called the county headquarters, the provincial headquarters. Before before 2010, that is the new constitution came into being. So you have one in Eldoret, one in Kakamega, one in Kisumu, one in Nakuru, one in Nairobi, Mombasa, Garissa, Nyeri, and Meru. And then, of course, we have the national depot in Kitengela. So that is the portfolio of our vaccines. We have top among them BCG, that is usually given at birth. Then you have the polio vaccines. We have 2 polio vaccines. One is oral, one is injectable. So I think, as you can see in the screen, that is basically the schedule of our vaccines. So largely, of course, targeting the children who are under 1, that is BCG, OPV, pentavalent, or DPT. And then we also have measles, rubella. Most importantly, I think at this point to mention is that for measles, rubella, and malaria, we usually give the second dose for MR in the second year of life, that is 18 months. And then for malaria, we have a further dose that is usually given at 24 months, should be 24 months, sorry for that. Then we have some vaccines that are usually not present in the entire country. That is, for example, the yellow fever vaccine. It is usually present in the high-risk counties. That is Elgeyo Marakwet, West Pokot, Turkana, and some parts of Baringo. And then, of course, I had talked about the HPV vaccine, which is usually given to girls between the ages of 10 to 14 years. And then, of course, later on, of course, we are planning to introduce what is called the typhoid conjugate vaccine, which is due this year. And I think in the coming days, we'll be talking to you about it. So basically, when it comes to funding for our vaccines, we are largely donor supported. That is for almost all the other vaccines that I've talked to you about, except at the tetanus, diphtheria, BCG, measles, rubella, and OPV. Those are usually, just funded by our donors, largely Gavi. So might be interesting for you to note that we are continuously looking at, of course, expanding our portfolio to deal with what we can as far as vaccine preventable diseases are concerned. I have talked to you about the issue of TCV that is due for introduction some point this year. But most importantly, I think this has come up quite often when we have this kind of discussion with other healthcare providers. We have a very delicate balance to do when we are considering new vaccines. So, for example, we have to take into consideration the fact that we have to bear part of the cost. Most important for me to mention is that even where we are talking about donor-funded vaccines, the donors don't fund the entire amounts. We usually have what is called a co-financing agreement, where we basically share the proportions of the funds that we usually of the cost. So, for example, this year we are doing almost 60%. That is the Kenyan government, vis-a-vis 40% that is catered for by the donors. But not to it, I think this is going to come up later on, the issue of vaccine fatigue, and we also have our own programmatic limitations. Of interest to you in this case might be things, vaccines like the RSV, that is the respiratory syncytial virus. We have talked to pediatricians. They have said they have been seeing this a lot. That is still one of the vaccines that is part of what we might consider in the long run. We have adolescent doses of tuberculosis. We have vaccines for dengue fever, hepatitis E, Mpox, and group B, streptococcus. So those might be things that might interest you in the larger, healthcare space. But more to what I had mentioned, remember we said that traditionally, we have been associating, vaccinations with children, especially under below 1 year. But when you look at our vaccines portfolio right now, we are able to take care of, pregnant women by giving the tetanus diphtheria vaccine. We also have our COVID-19 vaccines still with us. Most important to mention, but I think also since 2019, we also were able to introduce the HPV vaccine that is able to take care of our girls. So when you look at the continuum, our continuum of services is basically all around. And right now we usually talk of life course vaccination and not just childhood vaccination. So we are supported by core elements within the program that are able to, basically enable us to do this vaccine, offer immunization services. We have vaccines, supply and quality and logistics. We have our service delivery and the capacity building arm. Then we also collaborate with vaccine preventable disease surveillance, which is an independent division within the Ministry of Health. We have a very strong and robust monitoring and evaluation and reporting department in our program. And then of course, finally, we also have a very robust advocacy and communication and community mobilization program. I think I have mentioned basically most of what is highlighted in that slide, but just to move on, talk about more about our performance over the years. Of course, we have seen tremendous gains when it comes to vaccinating our target populations. We are not there yet, but we have done quite a bit. We have, when you look at all the antigens, in most of the cases we have coverage, especially for the first doses, of more than 80%, which is quite commendable. So if you are considering, 80% of a target population of around 1.7 million, you can do the math. So we have quite some reach. Although, like Dr. Collins had alluded to, we still have challenges that coverage is not uniform across the country. We still have pockets within the country which are facing these challenges when it comes to immunization, especially the ASAL areas. Not all of them actually, but in some cases, mostly along those areas. But most importantly, also, we are now coming to this understanding that even in the urban areas, especially in places like Nairobi and Mombasa, we still have children who have not received any vaccination whatsoever. And those are the children that we are now calling the zero doses. So basically, that is just highlighting the numbers and the detailed performance for the various antigens. Now, basically, I think at this point I would want to talk about the bulk of what we are currently doing that is in line with our theme for the immunization week this year. We have had a lot of catch-up vaccination attempts. When we talk about catch-up, basically what we are saying is that we are trying to see whether we can reach those who ought to have been reached. All right. So if you have instances where, for example, a child was due for vaccination last year with measles rubella and they missed a measles rubella dose, then we try and see whether we can get to them and give them the vaccination. So we have this initiative that is supposed to be running through this year, and that is called the Big Catch-Up Vaccination Attempt. So if you happen to see our teams down there in the community, offering to vaccinations to people who are beyond the first year of life, that is 2, 3, 4 years, who apparently had missed chances of vaccinations, please understand that this is what is happening. But more to it, we are also planning, of course, to be doing a national campaign that is for measles rubella and the typhoid conjugate vaccine. So at some point, of course, we'll be communicating this officially. That will happen this year. We are also planning to introduce a second dose of HPV. I think those would be the most important for you in this call. But basically, that forms a part of our other effort, apart from what we usually do routinely with routine immunization. So I think at this point, I would want to say that as I try to conclude, that we have made very significant gains over the years when it comes to availing these vaccines to our people, that is the people in the Republic or the country. We still have our own challenges, but we look at these challenges as opportunities for us to improve further. Dr. Collins had talked about the unique things that we usually have with vaccines. We store most of our vaccines at a temperature of between 2 to 8. That is now supposed to be uniform, whether you're talking about vaccines in Nairobi or whether you're talking about vaccines in Turkana or vaccines in Wajir. So quite a huge responsibility for us. We have luckily been able to do that, but we are still continuing, to expand our capacity. So, like just this year, we have had several rounds of, purchases of this cold chain equipment that are earmarked to help with the service delivery. So we have also been able to pilot and introduce new vaccines that are of public health importance. So I think we recently did the malaria vaccine. Some of you may know, some of you may not. I think just in the past 5 or so or 6 years. And then, of course, we are also planning to now introduce the typhoid conjugate vaccine. Now, it is important for us that, for the fully immunized child, our coverage is still, just around 80%. We have 20% to go, but 80% is also a commendable, performance. We have our own challenges, and I think that is part of what we will be talking to you about in this call. we have pockets of people who are not very receptive to vaccination. That especially happened after COVID. For whatever reasons, we are going to be talking to you about that. We still have the zero doses that I've alluded to. We have inequitable access of immunization services to the vulnerable populations. Our coverage is usually affected largely when you come to the second year of life or beyond that of vaccination. Most of the people think that vaccines are supposed to be given to children for whatever reason. That is not the case. That is children are under one. That is not usually always the case. And of course, we also have reduced risk perception by the public of vaccine preventable diseases. Occasionally, very occasionally, we have also had issues with the stocks. So finally, I think I would want to request that if we can look at partnering with what we are doing in the ministry in ensuring that we make sure that anybody who is eligible for vaccination get their vaccine so that we can end all these vaccine preventable diseases. Thank you.
Thank you. Thank you so much, Dr. Mugambi, for taking us through the expanded program of immunization, its history, its organization, through the schedule, through the different thematic areas, and also the focus on beyond infancy, looking at life course vaccination, as well as the program successes and challenges. I know there'll be more questions that will come up during the Q&A session, and some are already in the chat that we will address during the Q&A session. But now, before we get to the Q&A, I'd like to invite Dr. Zimba to briefly take us through the WHO reflections on World Immunization Week, after which we will have an opportunity to respond to some of the questions already on the chat, as well as ask any additional questions. So, Dr. Zimba, over to you.
All right. Thank you very much, moderator, and also the previous speakers that have spoken well, almost everything. So, Ruth, I just want to check. Do you want me to share the presentation, or just have to
Yes.
talk about?
If
Okay,
you're
then
able
let me.
to, yeah, that would be great. We have a hard stop at 3:30, so we can just take a very compact time. Yeah, thank you.
Yeah. So where do we go to share? Confirm if you can see my presentation.
Yes, are you able to share on slideshow?
How much time can you wait?
Yes. Is that okay? Just can you see in the slideshow now? Are you able to see the slideshow?
Not from my end. I think it might be a technical setting where maybe you're not able to. But I would just like to, unless Nelson, you advise otherwise, maybe we can just continue for the purposes of saving time. But we are not able to see it on slideshow. But you can still continue, Dr. Zimba.
But you can see my presentation, right?
Yes, we can.
All right. So thank you very much. Okay, thank you very much. First, I really want to appreciate the organizers for this meet. I think these are the kind of engagement that as people working in the immunization space, we need to have with health workers, but also even the caregivers, because I think these are the platforms that can help us maybe to share in terms of what's happening in the immunization space, but also at the same time being able to respond some questions that would be helpful. So I'll not speak much to these things. I think my colleagues, Dr. Tabu, and also my colleague from government has already spoken in terms of the benefits of immunization, really. But I just wanted to say that immunization started some time back, even when we talk to the time of Edward Jenner, when he took cowpox and injected in the Philips. and that's how it started all together. But formally, as expanded program on immunization, this was now launched in 1974, and that's why last year I think the global immunization stockholders around the world were celebrating 50 years anniversary of immunization. But also to say that it's a fundamental right. So as such, it means it's a shared responsibility and vital investment in our future, particularly when we're talking about healthcare investment. In terms of other statistics, my colleagues have already shared, but also just to say that despite all these efforts that have been made in immunization, the efforts that our colleagues have mentioned about, there are still some challenges that are there. For example, as we're talking, 1 in 5 children in African region remain under vaccinated. So you're talking about around 20%. Even if you use Kenya's data, if you look at 2024 data by December, you see that our coverage is, if you just take Penta 1, it's around 83%. Um, what it means is we are missing 17%, which is almost also closer to 20%. So this is a huge number. And also, even Dr. Tab mentioned about data from KDHS, where it's talking about 1,000 zero dose children. So it means every now and again we're having this accumulation of children that are not immunized to all these vaccine preventable diseases. And as such, we have seen within the region lots of measles outbreaks, some parts of the region, but also even in our country here, we have seen also a lot of counties actually reporting measles. But also lately, we have seen also a emergence of polio vaccine and vaccine-derived polioviruses. We just finished responding to circulating vaccine-derived poliovirus 2 in 4 counties within the country, but we also see a lot of cases that are coming from Ethiopia, Somalia, Djibouti, and other countries. All this is just speaking about in terms of the challenges that we're facing as far as immunization is concerned. So this year, when we're talking about immunization week, so the theme is immunization for all is humanly possible. It's just about calling all of us that it's possible to strengthen our system and be able to reach all the children that are supposed to be reached. And I think other colleagues have already spoken to. But one of the, I call it the Bible of immunization. Every 10 years, usually there is a guideline that guides or that stipulates in terms of what would be the aspiration of immunization globally and regional, and also countries actually are supposed to develop documents that should speak to that. And we have Immunization Agenda 2030, which replaced the Global Vaccine Action Plan on Immunization 2010 to 2011 to 2020. Actually, Immunization Agenda 2030 actually stipulates in terms of what are the strategic objectives and the core principles on which immunization system should anchor in as far as immunization concerned, but also for us to be able actually to reach every child and leave no one behind. This also actually it's also in line with what Gavi 5.0 strategy was also using. Of course, I know now there is now very soon we're starting Gavi 6.0. Yeah, so in terms of WHO, so WHO's role in as far as immunization concerned, before I talk about our role in Kenya, but I also want just to speak in terms overall at a global level in terms of what's the role of WHO in as far as immunization is concerned. So there are critical areas that WHO provide leadership. Number one is to provide technical guidance. So at global level, there's what we call strategic group of experts on immunization, which is independent experts that evaluate evidence and provide guidance in terms of the need for vaccination, how that vaccination should be applied in the countries and all others. So it's like the library. This is the committee actually that sets up that guidance that the global we should follow, and it trickle down to regional level. You see the similar structure exists at regional level, which is called regional immunization technical advisory group. So it also plays similar functions that within the region they should be able to provide guidance that are tailor-made to the region's challenges. And then if you go to country level, now you have National Immunization Technical Advisory Group, which also plays similar functions. Dr. Tabo and colleague, they talk about that we're introducing TCV and all these vaccines that we're introducing for a country. Before they introduce a vaccine, it means NITAG, National Immunization Technical Advisory Group. They have to sit and look at the evidence in terms of the characteristic of the vaccine itself, the countermeasures, the disease burden, the public health importance of intervention, and all what have you, and then provide recommendation to Minister of Health for the need of the country to introduce that vaccine. So that's in terms of technical guidance part, and as far as new vaccine introduction is concerned. But also it's also mandated actually to develop guidance in overall implementation, whether you're talking about supplementary immunization activities like campaigns, how they're supposed to be implemented, even the service delivery itself, how to run immunization session, whether it's fixed or outreach and mobile immunization session. So WHO has got that role that they have to play at all levels. And then another important lower global level is to support regulatory functions. Maybe colleagues, you have ever heard that this vaccine is WHO purely qualified. So it means apart from regulatory authorities that the countries do have that look at the vaccine, they assess the quality, safety, and efficacy of the vaccine. uh, the market authorization holders, in this case pharmaceutical companies, they can also apply for what we call WHO pre-qualification, because it gives them a better market, a wider market for their product. So it means WHO has that capacity at that global level in terms of providing guidance and actually providing the pre-qualification status of the product, so that they can be even procured by UN agencies like UNICEF, but also even be supported by Gavi. For Gavi to buy the vaccine for UNICEF, Dr. Tabu can agree with me that the vaccines at the moment or products, they have to be pre-qualified by WHO. And also another important function is they monitor trends or uptake in as far as immunization coverage is concerned. We do also together some of these functions we do together with other global partners, UNICEF and other partners. We're talking about IGFR, which is a reporting tool that countries have to do. We're talking about WHO UNICEF immunization data we call it unique, which is usually the data that you usually actually cite when you're talking about the coverage of. So all these, they help us to understand in terms of how we are doing at sub-regional, sub-country, country level, but also even a regional level as a whole in terms of how immunization is concerned. But also importantly, also they provide also guidance in as far as vaccine preventable disease surveillance is concerned, and monitoring trends and see
Sorry,
there's outbreak and how that
Dr.
outbreak.
Zimba. Sorry to interrupt you. I
Hello?
don't know if
Yes.
we are not seeing your slides moving. I don't know if you're able to just
No. I'm not
Yeah.
moving the slide at the moment.
Okay, all right.
Okay. Yes. So I was just speaking in terms of the global overall functions of WHO. So all these functions that I mentioned, they also trickle down in terms at the national level. And even here in Kenya, we do support KENTAG. Here, National Immunization Technical Advisory Group for Kenya is called KENTAG. We make sure that we have that convening power, that we provide that important information. We also provide, I will show some examples in terms of how we provide in terms of data support, but also VPD surveillance and outbreak response. Recently, I think in February, we responded to a measles outbreak in Garissa and Wajir, and we have also just completed responding to polio outbreak with other partners like UNICEF and other partners. Also, supporting counteract misinformation and strengthening vaccine confidence, as Dr. Tabu said, but also provide technical support in terms of monitoring of vaccine safety from vaccine development itself up to the end when the vaccine is with the end user. So this is just an example of what we do in terms of modern day, the trends of uptake. So here it's 2024 data for Kenya, and you look for BCG, pentavalent, measles 1 and measles 2. And with this, we are able actually to develop trends, but also to have an idea in terms of what's happening, but also in terms of if the uptake had to remain the same, are we anticipating maybe any outbreaks in as far as vaccine preventable diseases is concerned? These pictures are just showing in terms of when we had measles outbreak response in Dadaab, as well as in Wajir. So this is also support that WHO country office here in Kenya also providing as far as immunization concerned. As I said, we always, almost wherever UNICEF is, WHO is there, almost where WHO is, UNICEF is there, and we make sure that our support is well coordinated, and together with UNICEF, we make sure that we give the Minister of Health the optimum support possible. The Minister of Health actually. And then this is talking about just ended the polio campaign. Now I wanted to speak just 2 minutes on this. Why I said this meeting is very important, and one of the things that come out that WHO started talking about this, but if not, I just thought it's important that we provide that pictorial view. What happens in a country when there's a disease but there's no immunization? That's stage 1. So you see, there's a disease, but it's very high, but there are no side effects of the vaccine because there's no vaccine. And now stage 2 is talking about when the vaccine has been developed and you have started using that vaccine in a country, the coverages are going high. It means the incidence of the disease is going down. You have started now seeing the benefits of the disease. For example, if you look at polio cases from around 300,000 cases per year, now to they have been reduced by 99.9% of cases, which is huge. Now, what happens at that moment is that because you're applying vaccine, it means you start seeing some side effects with vaccine. Now, when the incidence of disease have gone to the level where you cannot notice, those children that were born maybe 10 years ago, they can know the importance of vaccine. And then they may start magnifying the effects, the negative effects of vaccine. And that's what you see now. And what will be the result? The result of that, the coverage will go down, and the fact that the coverage is going down, we will start now seeing the incidence of disease coming back. That's why you see the outbreak now. So it's easier to be comprehensive, particularly the generation that have not seen the vaccine before. And that's why it's important that together here, over 600 people, we need to carry this message that we do not see the diseases that they were there before, that our parents were battling just because of these vaccines. And it's not time actually to stop or to press the brake. It's time actually to make sure that we eradicate what can be eradicated. Now, in stage 3, once the outbreak has come back, people now start rushing for the vaccine again. It means you see the coverage of the vaccine goes up, and that's what can lead to eradication of that particular disease. Like, for example, my colleague has already mentioned 1980, that smallpox disease was eradicated. And it was also the desire of the global health partners to ensure that polio is eradicated. And we're at the very, very end of our eradication efforts in as far as polio is concerned. I just wanted to share this information because it's really important on terms of evolution of immunization progress, vaccine safety monitoring is concerned. So one of the WHO role is to make sure that we have systems that monitor the safety of the vaccine at all time. So to make sure that the adverse event are identified, if there are serious cases, investigation is done, and then there's causality assessment that has to undertaken to assess the relationship or association between the vaccine and the said event, and then provide feedback to the community, including other stakeholders. So what is needed now in as far as this immunization week is concerned? Remember when immunization week was launched in May 2012, the desire was that it should provide global public health campaign awareness and increasing the rates of in terms of the uptake of our vaccination. There are still some areas that we need to do. So I think more than ever before, we need to work together with partner WHO and other partners. We need to work together to make sure we identify all those children that were missed, not just zero dose, but even under immunized children, so that we're able to reach them. But also importantly, with the dwindling of the resources almost in all angles, it's important that we need to think through how we can integrate these systems, particularly the primary health care, so that we are able actually to utilize, to leverage every platform that is available, and also build stronger and more resilient health systems that will be able to help us to increase our access, but also as well as utilization. My colleague talked about challenges that we are facing in the second year of life immunization. Some of these challenges actually they can be mitigated through integration and also building a strong and more resilient health system. We'll continue also supporting the ministry in the introduction of new vaccines. We're introducing typhoid conjugate vaccine this year, but there are more and more vaccines that are coming that we should be able to support the country. So I just took a picture of strategic priorities and core principles of Immunization Agenda 2030. As I said, I look at this as a Bible of immunization program. Those colleagues that want this document, it's a very good document. You can Google WHO website about Immunization Agenda 2030, but I can also share with you, Ruth, that you can circulate. But why I presented this, my colleague talked about now we are no longer looking at the primary series vaccination where the focus was infants or those children 2 years and below. But we're talking about life course immunization. And for us to be able to achieve this life course immunization, integration is the key. That's number two. We're looking at in terms of how can we work together as partners. So if you look at the core principles, they said we need to make sure that our immunization, the strategies, the intervention that we're applying, we make sure they should be people-centered, country-owned. People say that they should speak to the people that we want to reach. It should be something that is practical to the area where we're working. Country owned, it should be owned by all stakeholders in the country, all of us here. Something that we know we can achieve with the resources that we have. And then partnership based. We should not leave any partner behind whom we know that they can play a critical role. So we are talking about either at national level or maybe county level, even at sub-county level. They could be important and key partners. And they should be data guided. I've seen my colleague from NVIP. He presented very important data. Dr. Tabu mentioned about important statistics. So we need to make sure that our interventions are speaking to the data that we have now at the moment. If we're able to incorporate all these principles to the best the ability of a human being, we will be able actually to increase access of the immunization of all these vaccines to everyone humanly possible. Thank you very much, and back to you, Chair.
Thank you. Thank you so much, Boston. That is a very passionate presentation around immunization and particularly on WHO's role. I hope we will all be able to refer to the immunization agenda that Dr. Zimba has referred to. And I'm sure we'll also be able to get the presentations after this so that we can also look at them and get more information. So we have 15 minutes remaining towards the end of this webinar. There are a number of questions that have been raised on the chat. So as we wait to get more questions, I know there are some that have been responded to still on the chat, but allow me to just raise a cluster of questions which the speakers can respond to in this session of the Q&A before we come to a close at 3:30. So I'll take the first 5 questions. There's a question around the campaigns, the mass campaigns that we've had. An anonymous attendee is asking, please clarify on which OPV vaccines are given during the mass campaigns and spacing of these vaccines. How do you explain to a parent who got OPV at birth and then within a week there's a mass campaign offering another dose of OPV? There's a second question around vaccine hesitancy, mostly around polio, the most recent polio SIA campaign, and also with MR and the outdated concerns around the MR and autism linkages that have been made. So the question, I think, is around with the upcoming catch-up immunizations, what has been the approach to vaccine hesitancy? There's a question around flu vaccines. Is there anything like too many flu vaccines in one's lifetime, considering the different campaigns that have come up? I've seen Dr. Tabu is responding to that on the chat, but we can speak to it. And then COVID-19, please address well-documented multiple adverse effects of COVID-19 vaccines, including myocarditis and all this infertility, pericarditis, pregnancy losses, stillbirths, and all that. So that's also a question from Edda. And then maybe we can address those ones and then we can look at the remaining questions. So I'll invite the speakers to just speak to those. Any of the speakers can respond to any of the questions. Then we'll take another round of questions. Over to you. Maybe we can start with the OPV and the spacing and the types during campaigns.
So, can I take that?
Yes, please. Please go ahead.
Yeah, so thank you. Thank you very much. In 2016 countries, according to Global Polio Eradication strategy, actually, was that the countries should actually change from bivalent oral polio vaccine, from trivalent oral polio vaccine to bivalent oral polio vaccine. So trivalent had got oral polio vaccine that contained 3 serotypes, type 1, type 2, type 3. They had to change it to bivalent that contained with the 2 serotypes, type 1 and type 3, because by that time type 2 was eradicated. So they wanted to make sure that they're taken out of the market. So now the vaccine that is given in our NV program is OPV2, OPV bivalent, which contains the serotype 1 and serotype 3. When you're talking about the vaccine that we're using, the polio vaccine that we're using for the campaign, now I just have to speak to it that can you take it? First of all, we are responding to this outbreak because of circulating vaccine-derived poliovirus type 2. So because of that, the OPV that we are giving at the moment does not contain type 2 serotype. So the vaccine that we're using for the campaign is special for this campaign, which is called NOPV2, which is novel oral polio vaccine type 2. This is a vaccine that was developed to respond to circulating vaccine derived type 2, particularly because it was developed in a way that it is genetically stable. I'm sure I'm talking to health workers, so I know there's some, so that they're okay with the technical term. So the vaccine NOPV2 is genetically stable, which means its ability to produce circulating vaccine-derived poliovirus is lower than the usual monovalent oral polio vaccine. So if you look at in terms of the data that shows, in as far as if the child got OPV 0, there is no problem actually, even if they get this campaign vaccine, because we're doing it as a supplementary. So even the key messages that we give to communities, actually, because this is supplementary, it means we are supplementing of what is already in the system. One thing that we have to be clear is we are not substituting what is in the system. So caregivers are encouraged to continue doing the routine, to getting the routine vaccination as far as it is concerned. Even if it means they got it yesterday, they can still get the supplementary immunization dose today. There is no issue. Or even if they got supplementary immunization today and their routine immunization is due, for example, the day after tomorrow, they still have to go ahead, because this supplementary vaccine is not there to substitute the routine immunization, and there's nothing like overdose. So don't worry about the overdose. There'll be nothing like overdose if you get those vaccines maybe back to back like that. So on the same with offering another dose of OPV. I hope the first question has been responded. I don't know if colleagues have wanted to add something before we move to other questions.
I do not have anything else to add. I think Boston, that was comprehensive enough. And appreciating you for that, and for the other questions. Again, in the interest of time, we've got quite a bit of responses in the chat boxes, and that which you may not be able to respond to immediately within the context of this call, please feel free to reach out to us via email or otherwise. Thank you.
Thank you. So maybe we can address the question around vaccine hesitancy, particularly the linkage with autism. I've seen someone in the chat saying it's not outdated, and there's actually
I can
sorry,
speak to that.
you can speak to that. Please speak to that and all the questions
Yes.
around vaccine hesitancy. Thank you.
So yeah, I remember very well. It was 1990 actually when Andrew Wakefield actually published his paper in Lancet. Published his paper in Lancet when he was talking about the association of autism, of measles containing vaccine and autism. And usually for him, in his discussion, I think the culprit was thiomycin. However, it was noted that his publication actually had a lot of flaws. A lot of studies came behind that disproved that. And just for your own information, Andrew Wakefield, his license was revoked in the UK. That's number one. Number two, even the paper was retracted in the Lancet because it had a lot of fraud in terms of the way methodology. If there are some people that they want to know more about this, we can talk offline, but also they can lead around this. However, one of the things that came out very strongly was that that stimulated a lot of pharmaceutical companies and also other interested parties to study in terms of the content of the thiamycin in other products that we use actually on daily basis. And they noted actually that there are so many products that contain thiamycin in larger amounts that we use every day than the thiamycin that was contained in measles containing vaccine. So that's one of the reasons that why it was refuted. But also because of this, actually, I think actually pharmaceutical companies, they made a lot of effort to ensure that they remove thiamycin in the product. This is not to say that thiamycin was causing the autism, not necessarily, but just to make sure that they have the confidence of the caregivers that the product is of higher quality and there's no association between measles and autism. However, with that publication, it led to significant hesitancy in as far as immunization is concerned. If you look at the records, actually, from 1999, around 2000 up to around 2003, you see the coverages in high-income countries like Switzerland, Finland, England. They dropped very, very to the low, some to around 30-something% attributed to all this because as many people believed it. So as they were trying to, it was like now you are reacting to it. So that's what happened, and many people still caught that, and we see that also spreading to also other parts of the world, and we're even talking about this today here, which means it even also spread up to our countries. However, there are a lot of studies that have been done, but also as I mentioned in terms of the decision that were made in as far as that study was concerned, just to show you that there's a lot of fraud. Now we have a duty as immunization stakeholders or immunization experts to make sure that we provide accurate and timely information to caregivers. The accurate information that we know is that the vaccines, including measles vaccine, is one, safe, two is one is safe, two is efficacious, and three is of higher quality. And these are the parameters that even those that review the dossiers, the regulatory authorities, if you look at how vaccines are, in terms the dossiers for vaccines are analyzed, they can take almost maybe 2 months just looking at the quality aspect of it only, just to make sure that they're not missing anything. And even also in other parameters. This is just to tell you that because of all these things that are happening, misinformation around vaccines, almost all the stakeholders that are working in immunization space, they are doing their part to make sure that the product that is given to public is of higher quality, is as safe as possible, including the pharmaceutical companies, the regulatory authorities, and even immunization stakeholders in country. They make sure that the product that is given to the public is of higher quality. Now we understand the challenge that can come, actually, particularly in our setting, and that's why one of the strategies is to make sure we work together. If you see that there's a better way on how we can present this, it's important that we bang our heads to make sure that we present it in a way that people should understand. Though you and I, being medical people, it's easy to understand all this what I've said. But how can we make the very same message that we're talking here in a way that should be understood to caregivers? And that should be the responsibility of all of us. So we urge all of us here to be the ambassadors of this good news of immunization, to say this measles vaccination that some people thought that it was causing autism. That's not true. The truth is the measles vaccine is safe, has been studied, and has been applied, and there are no issues that have come with it. And if people want to read more, they can also consult authoritative websites or authoritative documentation that they can get correct information. One thing that we should know, anti-vaxxers will continue to be here. So it's the duty of all of us here that we're able to provide accurate information about immunization, not just measles containing vaccine, but any vaccines that are available. I hope, Collins, this is your field, particularly in UNICEF. Maybe you have one or two things that you want to add in this regard.
Maybe as Collins comes in, I can ask him to also combine it with the questions around COVID-19 vaccine. There's been a question there that talks about adverse effects from COVID and how we can support what has been called victims in the questions. So, Dr. Tao, please respond, and you can also touch on COVID-19.
Yeah, no, so thank you. Boston has been very, very comprehensive. Just to reiterate that vaccines are public good and not therapy. They're not like therapeutic medicines where we say, somebody can do with some discomfort just so that they can get cured. So they're public goods. They're given to people who are well, not people who are unwell. So the first and foremost principle is safety. They go through a long and rigorous testing and evaluation process, multi-stage, more than 5 stages before they can be allowed out into the market. And then within the countries, there are independent safety evaluation mechanisms. Within Kenya, we do have the Pharmacy and Poisons Board. There is the WHO out there. But beyond that, there is continued post-market surveillance where there is continued monitoring of the vaccines, just like any other pharmaceutical product as it is out there in the market, just to assure its safety. As vaccines are utilized, there's continued collection on data about adverse events, and we do have, and like I think Boston touched on these, there is a vaccine safety, an independent vaccine safety committee that is responsible for it, comprised of the senior most scientists within this country, and that evaluates all of the adverse events and other reports around the safety of vaccines. And these are analyzed scientifically and reported upon at the national level. Just like for COVID-19 vaccines, these did happen. The COVID-19 vaccines had an indemnity program in nevertheless, because the COVID-19 vaccines needed to be rolled out within a short notice to be able to stop the cycle transmission of the COVID-19 virus at the time. As you will recall, it was a pandemic and very many people were dying from it. So time was of the essence. The COVID-19 vaccines were developed within a short time and people were thinking, look, why not vaccines for other diseases? COVID-19 vaccines leveraged already existing infrastructure, already existing vaccine manufacturing platforms, already existing vaccine expertise, and leveraged the massive investments that were put in globally really to save humanity to be able to turn around the vaccines. So this is what I'd like to share. For any adverse events, perceived or real or otherwise, there is a system for reporting within the country, that through the health facility or through the Pharmacy and Poisons Board, following which then the investigation, the National Vaccine Safety Committee would follow it up and investigate. And if for the COVID-19 vaccines, if there was something that was determined that it was directly linked to the vaccines, there's an indemnity component for that, but it will go through rigorous investigation. Otherwise, quite a number of the adverse events that were alluded to COVID-19, a lot of it circulating around, like I responded to a question in the chat around the periods and all. There have been several articles that were published. A lot of investigation was done around these, and there was found to be no link, and we are happy to share a bit of those reports locally. Thank you.
Thank you so much, Dr. Tabu. I recognize that we are about 3 minutes past time, but I'd like to give Dr. Mugambi a chance to respond to some programmatic questions. And for any other remaining questions, we can always respond via email or hopefully in another opportunity that will arise. So very quickly, maybe in the next 2 or 3 minutes, Dr. Mugambi, there's a question around vaccinating preterm babies. What's the guidance from the National Vaccines Immunization Program on that, as well as geriatric patients? Also, there are questions around what happens when a child misses any vaccine as per the schedule. And also, there is a report of children being turned away from immunization dates because of flu. Is that right? And can they be immunized? So I've just summarized a couple of questions from the ministry side. There are questions also around if a child is due for malaria, is diagnosed for the same, can the child still get vaccinated? Maybe you can just respond generally to that cluster of questions, but in case of more information or more questions that need further feedback, we can take it off after the webinar to be able to respond to that. Over to you, Dr. Mugambi.
Yeah, Ruth, thank you. I don't know whether we are able to, because of the issue we have with time, go through each one by one. But what I would want to say is that we have a very comprehensive, national policy on immunization, one that is up to date. I think the last time that it was updated was just 2 years ago. So, for example, on the issue of vaccinations to preterm babies, we have, we basically do not have a limit, our vaccinations. So, for example, specifically when you talk about BCG, we do not, say that children who are below a certain weight category should not be vaccinated and what have you. I would really, I think we have tried as much as possible. I don't know whether our participants are able to see the responses that we have made on the chats forum. We tried to do a lot of detailed, answers to most of these questions. I don't think with the limited time that I have that we will be able to do justice to them. But as Dr. Tabu had alluded to, we are always open and ready to, have all these, questions with us. You can do official emails to head.epi@gmail.com, and we are always able to respond to that. I think unless there's something that is burning, I would want to leave it at that. Thank you.
Thank you so much, Dr. Mugambi. I believe that is acceptable. And I know that the speakers have been providing detailed responses to the different questions, and we are still available, as has been said. So in the interests of time, and also noting that people have other engagements that they would like to get back to, I would like to take this opportunity to thank all the speakers, Dr. Tabu, Dr. Zimba, Dr. Mugambi, for taking their time to take us through the presentations, and also to highlight the importance of World Immunization Week and that all of us have a role to play. We have heard that healthcare workers are the most trusted in the communities by our communities and caregivers. So let's use this week to be able to raise that awareness and let people know that vaccines work and we are able to move forward. So thank you everybody for your time, and we look forward to reconnecting. The slides will be shared. Thank you so much and have a good rest of the day.